Hi, my name is Rebecca Andes, and I will be doing my presentation on conversion disorder. So, just an overview of conversion disorder. These are the beginning things that we'll be going through. There's the DSM-5 criteria, development and course, prevalence, and then cultural and gender diagnostic considerations. So, for the DSM-5 criteria, conversion disorder is also known as functional neurological symptom disorder. One or more symptoms of altered voluntary motor or sensory function. So, a lot of times people will have double vision or difficulty swallowing. So, their clinical findings provide evidence of incompatibility between the symptom and recognized neurological or medical conditions. So, there's a disconnect between the physical symptoms and an actual physical cause. There's also isn't necessarily a neurological cause like a seizure or a tumor or something like that. It's psychological symptoms influencing physical symptoms. So the symptom or deficit is not better explained by another medical or mental disorder. The symptom or deficit causes clinically significant distress or impairment in social, occupational, or other important areas of functioning or warrants to medical evaluation. So a lot of times people will seek medication from physicians or evaluation from physicians and don't necessarily receive help for their symptoms because it is a psychological cause. So the coding is based on weakness or paralysis, abnormal movement, swallowing symptoms, speech symptoms, attacks or seizures, anesthesia or sensory loss, special sensory symptoms, like visual, olfactory, or hearing disturbance, and you should specify if it is acute or persistent. So, development and course, you can actually develop conversion disorder at any time throughout your life. But there are differences between if you develop it in your 30s or your 40s. So in your 30s, the onset, you're more likely of having non-epileptic attacks, and then motor symptoms are more likely if you develop the disorder in your 40s. So the symptoms can be transient or persistent. If you're diagnosed when you're younger, then you have a better prognosis than if you were diagnosed in adolescence or as an adult. And here I have sort of like the development of your likeliness of developing conversion disorder in this graphic on the right. Prevalence. So transient conversion disorders are common, but the precise prevalence of the disorder is unknown. It's kind of hard to understand where we see this, if it's more likely to be seen in certain cultural areas or with different populations. So it's mostly the reason why we don't really know a lot about this is because most people go to see physicians instead of mental health professionals because it shows up as physical symptoms. So the incidence of individual persistent conversion systems is estimated to be between 2 to 5 people out of 100,000 people per year. But again, those are very estimated because a lot of times people don't end up in therapeutic settings. Cultural and gender considerations. So on the right, I have this graphic that puts you at more likelihood of developing conversion disorder. Conversion disorder is more common in females by 2 to 3 times. And then again, around the graphic, you can see different instances. Changes resembling conversion symptoms are common in certain culturally sanctioned rituals. So if the symptoms aren't fully explained within the cultural context and they do result in distress, then it should be considered, the conversion disorder should be considered. But of course, if the person isn't distressed by their symptoms, then a diagnosis is not made. History of conversion disorder. Conversion disorder is also known as neurological symptoms disorder. The term conversion disorder was actually first coined by Sigmund Freud, who hypothesized that certain systems were caused by unconscious conflict. So basically, he was the first one who really coined the term by saying that neurological symptoms and psychological symptoms are causing physical symptoms. Conversion, so the word conversion refers to the substitution of a somatic system for a repressed idea. So repression of emotions and feelings and everything, Freud said, would turn into physical symptoms. Common symptoms throughout history have been blindness, paralysis, dystonia, seizures, swallowing difficulties, etc. So, continued, the conversion disorder was first known as hysteria, which is traced to ancient times, and it's the malady of female organs. So it was only diagnosed in women, and it was seen as something having to do with female anatomy. Basically, like something was going on in female anatomy that they couldn't really explain that was causing women to be crazy, in quotes. Then it was remedicalized during the Renaissance, but until then it was seen as a religious phenomenon, or sort of like something physical going on with females that they didn't really understand. So then, once theories in the 19th century acknowledged that the mind could influence physical symptoms, that's when Freud's psychodynamic theory took hold and contributes significantly to the study of hysteria, and paved the way for the idea of conversion symptoms and the idea of looking at it as a disorder and not just women being crazy. So an assessment, how do we diagnose conversion disorder? It is a really difficult thing to diagnose, especially because it's not often that we see people coming in to therapeutic settings with conversion disorder. They more likely will go to an actual physician, and unfortunately a lot of physicians will say something along the lines of you're faking it, or that it's not real, that their symptoms aren't real. But in order to diagnose it, usually go through a full medical and physical exam. We go through medical history, CT and MRI scans, and EEG, which look for evidence of the cause of a seizure, electrical changes in the brain, if something neurological is going on, as opposed to psychological. And currently, there are no specific psychological assessments to assess the disorder. So differential diagnoses. So there are many here, obviously, listed. So there could be neurological disease, but this can be differentiated through neurological assessments. Somatic symptom disorder actually can be diagnosed in addition to conversion disorder, but what is specific to somatic symptom disorder are excessive thoughts and feelings about the symptoms that you're experiencing. There's factitious disorder and malingering. So the diagnosis of conversion disorder does not require judgment that the patient is faking it, but evidence of malingering would rule out conversion disorder. And there's dissociative disorders. Dissociative symptoms can present along with conversion disorder, but rule out conversion disorder alone. So they have a co-diagnosis. Body dysmorphic disorder. The people with this disorder are more concerned with a physical defect and hyper-focused on that, but there are no sensory or motor functioning symptoms like there is with conversion disorder. Depressive disorder, heaviness of limbs, is a similar symptom that you could experience with conversion disorder, but the presence of depressive symptoms rule out conversion disorder. And then panic disorder, symptoms are episodic, unlike conversion disorder, where they have the physical symptoms constantly. And treatments. Currently, there is no Class 1 evidence supporting efficacy of treatments for conversion disorder, but there are treatments that are helpful to those suffering from the disorder. So, psychotherapy, hypnotherapy, narcotherapy, pharmacotherapies such as SSRIs, and the most common and effective is psychotherapy in terms of treatment. And then to the case study. So, a 20-year-old female reported to physical therapy with numbness and severe weakness on the left side of her body, specifically her leg. She also complained of moderate low back pain. The patient was recently involved in a bicycle collision with a motor vehicle 3 days ago when she was on her way home from school at a small community college. The patient reports that the vehicle clipped to the front of her bike while crossing an intersection, causing her to crash hard on her left side. The patient doesn't remember she hit her head, but she was wearing a helmet. She only recalls feeling very startled and dizzy after the collision, with a couple of scrapes on her left leg from the pavement. The patient was taken to the local rural hospital to screen for a concussion, which came back negative, and she was then released from the hospital. Since the injury 3 days ago, the patient reports her dizziness has converted to double vision, has difficulty swallowing like there is a lump in her throat, and notices occasional slurred words. Patient continues to have difficulty walking and loss of balance since the accident, and patient reports having increased stress and difficulty completing schoolwork in the past couple of weeks. So this is a difficult case to diagnose because she did have a physical accident that could be causing her symptoms, but since they have screened for a concussion and it came back negative and there is no seeming physical cause for her symptoms, diagnosis was conversion disorder with sensory speech and swallowing symptoms because her incident of being hit by a car was a traumatic experience. She has psychological stress that caused these physical symptoms. The treatment for her was physical therapy, speech therapy, and medication. And then for the discussion question, so there's this short 6-minute clip. It's basically about women who were misdiagnosed with conversion disorder, and they believe that throughout time, conversion disorder has been misdiagnosed in substitute of endometriosis, which is a serious ovarian condition that a lot of women experience. And basically, they claim that that women specifically are misdiagnosed with conversion disorder because physicians and mental health professionals don't believe that their physical symptoms are real. So my question for you is, the origin of conversion disorder comes from hysteria, which comes from pain associated with the uterus. Doctors have been misdiagnosing women's pain and symptoms for centuries. Women are today still diagnosed 2 to 3 times more than men with conversion disorder. How can we ensure, as future clinicians, that we are taking women's pain seriously and not misdiagnosing physical illness with mental? And here are my references and additional readings and media. A couple of videos in there like the one I shared. And yeah, that's all. So thank you. So I found this really interesting. There are a lot of theories around the Salem witch trials and what actually caused them and caused possible symptoms or the mass hysteria that went on during these times. And a big theory is actually that it was conversion disorder. So this medical sociologist, Dr. Robert Bartholomew, strongly believes that the Salem witch trials were a mass case of conversion disorder. He states that repressive family life and post-traumatic stress can bring on the disorder, something that the girls in the trials experienced, because a lot of the girls were actually refugees from a war during that time. So their symptoms that they experienced in the Salem witch trials are consistent with the symptoms that you experience with conversion disorder. So they had shaking, facial tics, trance states, speech issues, and similar issues actually continue into today, where in 2015 there was a group of students also in Massachusetts who developed chronic hiccups. So it was an isolated incident in this one school, in this one group of students. Many affected were athletes, and it was believed to be brought on by the stress of the sport.